I am from Cincinnati Children's, and, sorry, already off to a rough start. Other direction? There we go, okay. I am the Director of Systems Integration in our Office of Population Health at Cincinnati Children's, and I am taking a slightly different approach to sharing information. And that is because Cincinnati Children's is a giant organization, as you all know, and so it really broke my executive functioning to even imagine kind of going through the specific services that we offer. But instead, and kind of with the mission of talking about how we become better partners and deeper partners and really coordinate and leverage our resources, I thought what might be more helpful is to talk about the ways that Cincinnati Children's is really trying to think at more of a systems level and how those systems level initiatives that we have are driving some of the work that we are doing in coordination with many of the agencies that are in this room. So I wanted to start by sharing our 4 pillars of population behavioral approach. The first one, again, really apropos to this group here, is that we are really dedicated to working in coordination with our community partners. We share the care and responsibility for many of the youth and families that we are serving in Hamilton County across our organizations. And by being able to develop deeper collaborations and better coordination, we can really leverage the collective efforts of our systems in a much more impactful way that can help all kids and families be healthier. We also are very data-driven, and this is a passion of mine. So having been a provider at Cincinnati Children's for about 10 years before I moved to my population health role, I worked in complex epilepsy, and many of the kids that I saw were involved in lots of systems throughout the community. But it was such a struggle to really be able to understand who were on these child and family care teams, how to connect with community providers that were helping with behavioral health treatment or medication management or IEPs or whatever. And things are so busy when you're a provider that I ended up really operating in my own silo all the time and really left it to the families to coordinate that and share the care and integrate it and synthesize it and put it together. But really that does families such a disservice. And so one of the barriers that really, I think, creates that position is lack of access to information when you need it. At an individual youth level, who are the other people who are surrounding these youth, but also at a systems level. How are our organizations connected, and how do we create that continuity of care between our organizations that really reflects the movement of these individuals throughout our organizations, both at the same time and over time? We are payer agnostic, so all of our strategies are not geared toward commercial insurance or individuals served by Medicaid or people without insurance, but we're really trying to develop strategies that can help anybody. And we are equity focused. So one of the goals at Cincinnati Children's is to have children in our region be the healthiest in the country. And we really mean every single child. And we cannot be healthiest until everyone has the opportunity to live their healthiest lives, to live, figure out what their talents are, be really impactful in the world. And so that is one of the drivers of this strategic focuses that we have. So a lot of our pillars, or all of our pillars, really flow from the desire to try to mitigate some of the barriers that are driving the behavioral health crisis that is in front of us. We know that there are record high inpatient and emergency room department visits for mental and behavioral health. A lot of that ties directly to decreased access to care. So youth aren't getting the care when they need it. Oftentimes symptoms go on for a long period of time. They end up in crisis, then they can't get connected to the care that they need. And so things tend to escalate over time. thankfully I brought printouts as well. So primary drivers of the behavioral health crisis, decreased access to care. There's a workforce shortage. I don't need to talk to anybody in this room about the workforce shortage. And then certainly disparities amongst different populations about the access to care that exists. So I am going to go through in a little bit more specific things that Cincinnati Children's is doing to try to mitigate the barriers that occur in those different areas. But first I want to step back and share just a little bit of history and how the kind of world that we find ourselves in has also encouraged us to do some internal transformation. So historically, we still have 3 primary behavioral health serving divisions at Cincinnati Children's: psychiatry, behavioral medicine and clinical psychology, which is my division, and developmental and behavioral pediatrics. These divisions have tended to operate pretty independently, which is nice because we all have kind of distinct skills and different needs, and it's allowed us to right size and really be innovative in our fields over time. But it has also created, I think, situations in which we're not as coordinated as we could be. And certainly for any child and family navigating those systems, I think there are definitely opportunities for us to allow that to be a more coordinated approach within even our own institution. So we are developing the Mental and Behavioral Health Institute, which will be the umbrella, and it will allow opportunities for those 3 divisions to have shared leadership, but it also will create more opportunities for clinical integration, for research innovation, the development of shared policy and advocacy agendas, and certainly a more cohesive and impactful approach to community engagement and working in coordination with all of your organizations. So population health, some of the initiatives that I'm talking about in part will come through mental and behavioral health, but population health also takes the approach of spanning not only a lot of the internal population health, behavioral health initiatives that are going on, but a lot of the work that we're doing across the local area, the region, the state, and then the country as well. So initiatives that are flowing through Population Behavioral Health and Mental and Behavioral Health Institute will have a lot of through lines that directly address the different component or the different factors that are contributing to the behavioral health crisis. So one of the groups of initiatives that the Mental and Behavioral Health Institute and Population Behavioral Health will be working on is to increase access to timely and evidence-based services at all levels of care. We always say the right care for the right youth at the right time. We also want to be looking more upstream. So part of the reason we're in a behavioral health crisis is because we, in some ways, designed a system to be very reactive and to only serve youth and families once they met diagnostic criteria for something that had caused functional impacts in their day-to-day lives. So we are very focused with getting upstream. A lot of this goes with policy and advocacy. We can't give out services for free, as everyone in this room knows. So being able to get more upstream, to do more resilience work, strength-based work, parenting classes, going out into the community will give us a chance to serve families at a place where hopefully we can prevent a lot of youth from ever developing significant behavioral health conditions. And for those who do need that treatment, we're able to identify them, get them connected in a much more timely fashion. Certainly this speaks directly to some of the health equity issues that we know exist in behavioral health, is that there are kids who are less likely to be screened, less likely to be diagnosed in a timely fashion, and then less likely to be connected to evidence-based treatment as well. There will be a group, kind of a whole group of efforts focused on training and consultation. This helps connect to the workforce growth. So we know the behavioral health workforce tends to turn over a lot. And so when individuals don't have the chance to really get the experience and feel confident, it's more likely to contribute to burnout. It's more likely to contribute to outcomes that aren't optimal. And so, sorry, it's hard to do it without the slides for you to be able to see some of the visuals, so I'm talking more. But these programs will span clinical settings, our care management and care coordination programs, as well as community-based training. There we go. Perfect, thank you. And then finally, integration, so taking a very whole child health approach. Behavioral health has been challenging over time because in and of itself, it tends to be fractured and episodic. So you might get medication management with one organization, therapy with another organization, school-based counseling maybe with another. And then it happens separately and often in different organizations with different electronic medical systems than your physical health providers and certainly other child-serving systems. So trying to figure out ways where we can bring all of that together and really approach kids and families as whole human beings where we can get much more support around families. This pyramid is how we think about our continuum of care at Cincinnati Children's, with the bottom of the pyramid being home-based services, so things like Every Child Succeeds or programs where we're going out into the community, more prevention, resilience building, all the way up to the top of the pyramid, designed for services for kids with the most significant needs like inpatient hospitalization or residential treatment. So in order to provide greater access, Cincinnati Children's over a long period of time has been expanding the number of providers and ways to access those services across different levels of care, so things like telehealth or school-based care, integrated behavioral health and pediatrics, but also then really focused on developing specific programs to serve kids and families who have been underserved in the existing continuum of care. So by way of example, we have a new neurobehavioral partial hospitalization program at our new College Hill campus that is designed to provide that intensive treatment to kids with neurobehavioral disorders and then transition them back to their homes and communities, versus what historically has happened is this ping-ponging from lower levels of care to higher levels of care, neither of which meet their need and create more situations where individuals end up needing long-term care out of their homes. So some additional things to call out in terms of specific ways that Cincinnati Children's is trying to better meet the need and coordinate with other systems. We have behavioral health attribution. Essentially, what we are trying to do is there is a very good chance when individuals with behavioral health needs come into the emergency room, they're connected to treatment teams outside of Cincinnati Children's. It has historically been very, very hard for our partners in the ED to know which organizations kids are connected to for their therapy, med management, pediatrics, whatever it will be, and to be able to coordinate with those teams almost in real time to be able to do safe discharges home whenever possible, or to coordinate on the admissions and getting aftercare set up. So we worked with organizations in the community to figure out a way where they could send their patient panels to Cincinnati Children's, including what care those kids are receiving. So at any time when those kids show up to our emergency room or to really any of the services inside Cincinnati Children's, including inpatient, people who are in EPIC can look at the care team and say, oh great, this kid is in outpatient therapy with Lighthouse. I can reach out to Lighthouse to work on discharge planning, when historically that would have been really difficult to try to figure out. So we currently have 8 organizations sending us information on roughly 7,500 unique individuals receiving 12,000 community-based behavioral services weekly, so that our teams inside Cincinnati Children's can coordinate in real time with the providers outside of our organization. And the goal is to continue to expand that regionally. We have ECHO courses that are individuals who have expertise in certain parts of behavioral health are delivering training to community-based professionals, including pediatricians, therapists, school-based providers. Cincinnati Children's has doubled the number of ECHO courses in the past year to try to meet that need. Very recent initiative, there is a local learning network, and 300 community and school-based therapists have now been trained in measurement-based outcomes. And that matters because as we all learn together and we really focus on trying to understand how kids and families are doing and be able to measure that over time, we can get a better sense is the treatment working? Is this child at the right care? How do we come to a shared understanding with the family about how treatment is progressing, and then make decisions faster about what the most appropriate care for that child is, and if they need to go up or down the care continuum. It also creates an opportunity to try to increase access by when children are meeting treatment goals, we have set the expectation of this is what it will look like when we want to move you to maintenance and transition you down to a lower level of care, so that we can then create opportunities for individuals who have those needs to be able to get in. Neurobehavioral partial hospitalization program I touched on. Additional with training and education, we have now a psychologist who is the training manager for our care management and care coordination teams. Especially when it comes to Ohio Rise, a lot of our workforce isn't clinically trained. So they are working with some of the with the youth and families who have the most complex needs, and yet they're coming at it from a perspective where they might not have training in child behavioral health. What is evidence-based treatment? What is trauma-informed care? And so we have a psychologist who is dedicated to elevating the skills of those teams and is also providing training to groups in the community for free so that we can continue to elevate that workforce. We also, one of the gaps of care that we noticed in our community is we have a lot of individuals, we've talked about a lot of them today, who have engagement with the child welfare system, they have engagement with juvenile justice, and Hamilton County has been slower to be able to develop intensive home-based treatment, which is the opportunity for treatment teams to come into the home, to work within the family system, and to really create opportunities for that child and family to heal together and keep those kids and families together. So we worked to recruit youth villages to start their Child Intercept program in Hamilton County, which is starting up right now, and will be designed to serve individuals who have child welfare and juvenile justice involvement, with the hope that we can stop those crisis cycles and heal those families. More population behavioral health goals. I'm not going to read through all of those, but the slides will be available. Expanding integrated behavioral health, again, trying to get screening, trying to build resilience. We don't have to wait for kids to show symptoms to be able to talk about parents. Hey, anxiety is something that every child is going to experience. Here's what it looks like. Here's what typical anxiety is. Here are some strategies that you might use to help your child navigate that. Here's when you should call back when we think like, hey, this is starting to get a little bit more intense than we would expect. Let's work together on how to help that child develop more coping strategies to manage that. We are continuing to expand the learning network, our training and consultation, and then continuing to expand connection with our electronic medical records and our organizations to each other so that we can build up that continuum of care and have families experience behavioral health care in Hamilton County as a much more seamless and collaborative experience for them. One example of a specific multi-system project that we have done together is that many of the organizations in this room that are represented around that young person started working together about 2 years ago to try to reduce one of the problematic patterns that is happening, whereas youth get stuck in the hospital. So they're admitted to a higher level of care, but once they've met they've finished the treatment for the inpatient hospitalization, because there is a lack of access, because there are gaps in the care continuum to serve specific needs, they can end up staying in the hospital for a really long period of time, and it's actually detrimental to them. So a group of us in this room came together to figure out locally what we have control of. How do we streamline our administrative processes? How do we learn more about each other? How do we more efficiently leverage the resources that are available to us to help transition kids to the more appropriate level of care? And we have engaged in a number of different interventions. Again, you're welcome to read them, but I'm going to keep going for the sake of time. And the outcome of that is this work, in addition to many, many efforts at Cincinnati Children's, has actually started to reduce the number of what we call avoidable bed days, meaning kids are in the hospital when they shouldn't be in the hospital. It is not the best place for them. And we are able to start transitioning those youth to the more appropriate treatments so they can continue on their healing journey. And also we then have the space to serve individuals who would benefit from that level of care. We have also been able to elevate the lessons learned in our community to more statewide groups that are considering how to help the systems transformation on a state level. And so what we're able to do is we have changed what we can and continue to work on locally, but there are lots of system barriers that we all face that we really don't have a lot of power to change here. And that's when we're able to gather these learnings, share them up, and help create the systems transformation that we need, which then, when we come back to care, can help facilitate the work that we are doing. And that is it.
Thank you so much.